day that you blessed us with. We thank you for the blessings of life, the freedom that we enjoy, the fact that we live in a representative society, that we've been elected by our peers. Carson chose us to represent them. I pray today we would represent them well. I pray we represent you well in both conduct and discernment, God. We would do your will for the best of the citizens that we would want to well represent. In Jesus' name, amen.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Mr. Ray Brett, dental surgery today. He will not be with us, I don't think, and Dr. O'Phil Goins is on Zoom. So, I don't know how this thing's going to go, but I would ask if you want to say something, raise your hand. And you don't, when you speak, you don't have to say everything at one time. If I keep going around to you, everybody gets opportunity to say what they want to say or ask what questions they want to say. But we do need to keep some order today if possible. I'll start it off. I'm going to tell you the reason we're here from the chairman's standpoint. This is only my view, no one else's view. I've been dealing with Eastpoint, and I've been dealing with the opioid task force for a long time, and I've seen the shortfalls of Eastpoint. So I contacted Michael Lee, which is the DHHS director, back in early 20, and I was going to see if there was an opportunity for Bladen County to switch MCOs. And I had a meeting lined up with him, and can't think of the lady's name. And then COVID hit, and everything went down. So a few weeks ago, I got this message that the state had opened up the window since Cardinal was folded, I think in Mecklenburg and some of them counties, that the state had opened it up for if a county wanted to switch, now is the time to switch between now and June the 30th. I assume that's right. I don't know if that's true or false. That's what I was told. So the first thing I did, I went to talk to Mr. Cogdell. He's our Eastpoint representation. And I asked Mike, would he be interested in tree and come back to presentation for us? He was all on board. In fact, he told me, he said, Mr. Peterson, I almost went to you a year ago because I wasn't satisfied with Eastpoint. I said, well, why didn't you? So I talked to Mike, and he says, yeah, let's see what they have to offer, bring to the table. So Mark Gillespie, myself, Ray, and Mike, and Mr. Martin met with Tree a couple weeks ago, maybe. So after their presentation, everybody that was in that room was on board with switching. So Mike said, well, since he was representation of our board on Eastpoint, he said, I'll call the other commissioners and tell them what the deal is and fill them in and see where they stand on. So we were set to switch MCOs Monday night. And then the pressure started coming from Eastpoint. Pressure started coming out of Raleigh and everywhere else to asking me to hear Eastpoint out. So that's the reason we're having this meeting today. I agreed to hear Eastpoint out because I don't leave nothing on the table that can help our citizens in Bladen County. That's the only reason I'm having this meeting today, is to make sure I'm not leaving anything on the table. I know what Tree and said they could do, and it's a whole lot more than Eastpoint's ever done in Bladen County. I mean, it's by far top of the line for what they offer us. So that's the reason we're here. So if any commissioner has anything to say, I'll let them say it. If not, I'm going to turn it over to Eastpoint.
On the situation that y'all is talking about, I've been on board for 5 years, 6 years. And I have asked for certain things and certain support in certain areas. And they haven't been done. Certain things I have looked at and have asked and inquired about providers and different resources for the county, different situations. At one time, Carson came in, and I met with those guys. They was coming in trying to take over everything. Carson, they wanted to take it all in. I met with those guys, and they talked about everything they could bring, and all these things that Carson could do. Now Carson has folded, and they had one of the biggest scandals here, one of the yards on. But he came to me with all the good ideas about doing everything. It came to me, I said, let's go to Carson. But they had all the ideas and everything. Oh, they talking about big bucks, and the big bucks were got in trouble. And then I served on the board, and there's some things I spoke to Mr. Strauss about so we can clear the air. And certain things happen with Eastpoint situation by me being on the board of directors. I was a little bit perturbed about and upset about the way things were handled. Because I was sitting on the board, and certain things were coming by way of the county that I had no knowledge of it. And I had a concern that why didn't I know about the task force resources that was coming in, certain things coming into this county. And I had no knowledge of it at all. And I was being informed things that was happening and how they were being networked. So I kind of got caught between the 8 ball and the hard place, that I looked at things coming into the county that was coming from Eastpoint, saying Eastpoint sent this. Then I was looking at things I was wishing and designing to get into the county, and they were not coming in, and some of the resources that I was looking for were not available. And when I looked at that scenario, I kind of got to a point that I didn't want to say something that would limit what resources was coming to the county and start a conflict. So I decided I would just wait it out, see where things would go, and see what things trend there. When this situation happened and Charles approached me, I talked with Miss Sarah about it. I told her, yes, I was gung-ho because I felt like I was left out of the loop. Things were not being handled properly the way I felt it should be handled to a certain degree. And I was out of the loop. So when Trillion came in and offered what they was talking about, it sounded like everything I wanted to hear. And they talked about certain things that he said, they talked about different issues and some of the things I had also asked about. And Trillion came in and said, oh, we can do this, or we can do that, or we can do this and do that. And I said, well, that sounds like somebody's going to be doing things that I would like to see done. But after the situation got played out, and I got phone calls asking me about why we was moving, I shared the same thing that I'm sharing with you about how I felt about it. And their approach was, let us have an opportunity. So if you've been with you guys over 20 or 30 years, to tell you what we can make available, the resources we can provide, what we can lay on the table to the county, the type of relationship and a better working relationship, a better environment, and address some of the needs. They said, let us have the opportunity to do that. So I got on the phone, I called all these guys, and I told them the same thing. That I wanted just to let these guys come in and present what they could do. I think that would be no more than fair because we did this in a very untimely manner. We didn't even give them a chance to even respond to it. They knew nothing about it until it hit the news. So I think we should afford them the opportunity to present what they can do and provide to this county, and then make us a decision and keep an open mind. Because Trillion just said what they could do on verbally, they have committed to nothing. This verbally gave us what's the same thing Carson gave me, we got absolutely nothing. So as far as this type of commitment, I'd rather see Ms. Sarah Stroud. I'm on the board, I talked with the chairman. I said, if you guys gonna deal with Bladen County, we need something in a format that you are making a total commitment to do certain things that you say you're gonna do. That you will not just come in and give us a word of mouth. You will put this in black and white and make it an official document. And if we feel like we want to leave and you can't satisfy our needs and not meeting our requirements, then we want, I'll tell her, I will gladly tell you we're ready to leave. But I said, let's give them opportunity to present what they can do, and let all these other commissioners, because some of these guys are brand new to the board, they don't know nothing about Eastpoint, they don't know nothing about none of this stuff. So they need to hear what Eastpoint does, what Eastpoint is willing to do, and I said, give them at least that opportunity. To me, that is being fair about the whole matter. There's no other way that I can look at it. This is to be ethical and moral feel good about it. They should have opportunity to share their views on what they can do. And although should stay open-minded as to what's going on with this, and let them present their story.
So, I didn't mention the Cardinal, I'll get to you in a minute. I didn't mention Cardinal. The reason Cardinal didn't come back to Bladen County is because their CEO is being investigated in fraud. That's the reason. It weren't because of what they could offer or not offer, it was
But I'm
because
saying-
of their CEO.
No, but when I met the guy, I was offering everything, he was offering the work.
One thing I would like to know, I wasn't able to be at that meeting. I'm a healthcare provider, so I know it's a lot of the, you know, whatever you want to call it, the backstories, been with Blue Cross Blue Shield boards on different things, blah, blah, blah. But one thing for some of the people on the board, I wanted to know what are the shortcomings, and Charles Ray, maybe you can speak up. Mike, maybe you can. What have been the shortcomings of Eastpoint that Trillium was going to come in and do? If I'm going to vote on something, I want to know kind of what the differences are, instead of a blanket statement, Trillium can do more. I was just wondering what, you know, specifically what is it that we're lacking right now? The other statement I wanted to make, it was kind of told to me that, and if I'm wrong, then excuse me, but we talked about, you know, you mentioned Cardinal folded, you know, it was kind of told to me that Eastpoint, if Bladen doesn't continue to be a viable entity for Eastpoint to service, that Eastpoint might be in some difficulty there with, I don't know that to be true. If not, you know, please excuse the statement, but I also want to make sure, you know, if you're referencing back to Cardinal, that Eastpoint's, you know, healthy and they're viable and, you know, this type of thing. You know, so just a couple of concerns there, so. And maybe those differences will come up in their presentation.
Got the, before we leave, the
Okay.
questions ain't been answered, I'll get you an answer.
Okay.
Anyone else? I'll turn it over to Eastpoint.
Thank you, Chairman Pierce. So I've got an entourage today. As they come forward, Kelly and Victoria, if you just want to sit there. I have a couple of guests with me today. If you want to stand too, Mr. Jones. So first of all, I want to say thank you because we appreciate the audience today, and we appreciate our representative on our board, Mr. Cogdale, being willing to advocate to allow us the opportunity to share with you not only what Eastpoint does and has done, but what we would propose to do moving forward. Because I hear you loudly and clearly that there are issues that you would like addressed. I am rock solid on those issues, and we're going to talk about those today. But first of all, and I think this is really important, because we do have 4 new board members, and I've been down here a number of times through the years to present to the county commissioners. I've spoken with your county manager a number of times. But there's 4 new people here who don't probably know very much about Eastpoint. You only know what you've heard in the last couple of weeks. So I'd like to really talk about what we do. I've asked these ladies to join me, and I'll introduce them in a minute. But then we'll move forward with how we can enhance going forward if you're agreeable to that. But first, I want to introduce our board chair from Eastpoint. This is Mr. Jerry Stevens. He is from Robinson County, former county commissioner, and we are very fortunate to have him with us today. I'm going to ask him to say a word. And then we also have Jerry Jones, who is from Greene County. Mr. Jones is also a county commissioner in Greene County. So I'll turn it over to you, Mr. Stevens.
Thank you, Ms. Rouse. Mr. Chairman and board members and our board member, Eastpoint, Commissioner Cogdale, we want to thank you for giving us this opportunity to address you today. I think it's one thing that we're delighted for you to do for us, because you basically didn't have to do it. But I do know that living and born and raised in Robinson County, we have all the same needs that Bladen County, being the same type of rural county. And we've always had a need for services in Robinson County. And we've had our opportunities to address the Eastpoint Board of what we thought Robinson County services should be looking like. And they've answered all of our requests because we've made them, and they're willing to learn. They know the importance of Robinson, Bladen, and these counties. And so we want to thank you again, and I'm going to turn it back in the hands of Ms. Sarah and just say how delighted we are to be here today. Thank you very much.
Thank you, Mr. Stevens. So So I also want to introduce these ladies sitting here. Victoria Jackson is a native to the southeastern counties down here. She is our Chief of External Operations. That's a fancy title for she knows everything related to providers. And I know she and Mr. Peterson have had a number of conversations around providers. She's going to drive for us, but also be here to address any questions. And this is Kelly Carson, and Kelly is our Chief of Clinical Operations as well as our COO. And she knows all the stuff about the clinical pieces. And I'm going to ask both of them to talk in a few minutes. So, but if there are questions that come up during the presentation, if you all wouldn't mind to make note of those, and we'll be sure and get everything before we leave today. So let's talk a little bit about who Eastpoint is, what we've done so far in Bladen County. If you want to advance to the first slide. I already introduced the team, but I think it bears noting that you've got about 16 years of experience sitting here. I've got 23 years in behavioral health. I'm a CPA and a licensed psychological associate. Kelly, you got 18 years, I think, if I looked at my slide, and Victoria has 19 years, all in this MCO world, and they are both licensed clinicians. You can see their credentials there, so they bring a lot of experience to the table. And they're only a small segment of our executive team, but you can see we do have a lot of expertise. We're a great team. We work very closely together. In fact, both of these ladies have had some personal hardship in the last couple of weeks. Neither one of them should really be here today. But I asked if they could come, and both of them said, we'll be there. So that's the kind of commitment we have from our team to Eastpoint, and you will see to your members. So just a really brief history for our new board members on how we got to be where we are now. I think it was, I don't know who said it, maybe Mr. Cogdell said it. We've been around for a long time. So area authorities were born in the 1970s. And we worked, when they were originally came into being, I think there was an area authority that provided behavioral health care services in every county in North Carolina. I think that's how it started. But in 2005, you all were talking about Cardinal. Cardinal was Piedmont before it became Cardinal, and they were set up by the state to do a pilot to become what was called a local management entity. And by 2008, all of the existing area programs at that time became local management entities. And that's a long term, and all that meant is we were no longer allowed to provide services directly. So Eastpoint, Trillium, Cardinal, none of us can meet you in an office and provide services to you. By contract, we cannot do that. And so we had to divest. And so many of the people who worked for the area programs at that time went off and formed provider organizations. And that's really how this whole provider network of behavioral health care people started in North Carolina, because before that, they worked for the area program. But then in 2013, we got another iteration, and we became LME MCOs. And we were allowed to manage the Medicaid dollars related to behavioral health care exactly like an insurance company. And Dr. Ellis, I'm sure you know exactly what that means. Services have to be medically necessary, they have to be authorized, and then Eastpoint, any other MCO, we're the vehicle that pays the claims. So that's just a little history lesson, and we're going to talk, it's getting ready to change again in just, what's today, the 23rd? So in 7 days, we're getting ready to change again. Just a little overview about Eastpoint. We have 304 employees, and I think it's worth noting that 11 of those employees live in Bladen County. I ran the numbers on what that means in terms of dollars, because I know you all are always interested in tax base and what people are making. And with benefits, that's about $1 million in salary and benefits for those 11 people that live in Bladen County. Our organization is very diverse, and it really reflects our communities, because we live in very diverse counties. And so about 47% of our organization is Caucasian, 42% African American, 10% Native American, because that's a really important component in our counties as well, and then just a small fraction of Hispanic and Asian. But I think that diversity in our workforce also reflects the providers and our communities that we serve. As I said, we are 10 counties that are kind of that just inside the coast swath, almost to Virginia. We don't quite go to Virginia, but we go all the way to South Carolina, as you know. So, next slide. We're frozen. I want you to see the next slide because it's kind of a pie chart that represents all the counties and the percentage. While she's advancing now, I'm gonna grab my water real quickly.
Let's get sort of Robin.
There we go. So I don't know if you can see that, but Bladen represents 5% of our total Medicaid population. Our total Medicaid population, and that varies depending, people go on and off of Medicaid, right? But it's around 227 Medicaid members for the whole pie chart. Okay, so let's go to the next slide. And let's talk about last year. So this is fiscal year 20. So the number of people in Bladen County that receive services, almost 1,300. And we have two funding sources primarily. We have Medicaid, and then we have a small pot of state money that is given to us by the legislature. And that's for people who have no insurance, who aren't on Medicaid, who don't have Blue Cross Blue Shield. They don't have a payer source. So we provide those services. And 264 people were served with state funds, 1,029 with Medicaid services. I think it's interesting to note, and I've heard a lot of commentary about our call center. And for those of you who may not know, we do operate a call center. It's open 24 hours a day, 7 days a week, 365 days a year, and there is a 1-800 number. 981 of the calls last year that the call center took came from people from Bladen County. And I think that's interesting because it really matches up closely with the number of people served. I can't say there's a direct correlation there, but it appears that people are using the 1-800 number to access services. Okay, so these numbers are your claims numbers, and I can hardly see them, and I doubt you can. So let's just read them from my paper. So what we're doing is we're comparing the previous fiscal year to this fiscal year in terms of claims paid. And so in fiscal year 19, we paid $8.4 million in claims. That's Medicaid B, C, and state funds. In 20, we paid just over $10 million in claims, $10,048,935, serving those 1,293 members. The difference between those 2 years, we increased the claims we paid by $1.6 million. What's interesting to me, and again, I'm not running a scientific study here, but just looking at data, which I find interesting. In 19, we served 1,263 people. In 20, we served 1,293, but we paid almost $1.6 million in claims. Now that could be for a lot of different reasons, but one of the things that we've done, and I have a slide that we'll look at, but one of the things we've done is we have invested in our providers, and that's how we invest in our communities. So we have given, as I said, we'll look at the slide, but we've given over $21 million in increases to providers to help stabilize them. Specifically, when COVID hit, and we all know that one minute we're sitting, you know, we're out in the world doing our thing, and the next minute we're all locked up at home, right? So during COVID, we gave $6.5 million to our providers to help them convert to telehealth, to help them stabilize, because they were hurting, to keep them in business. Because we knew eventually we'd come out on the other side of COVID, and we didn't want to lose our valuable providers. As you can see, Bladen County gives their maintenance of effort of $48,725,000. Every year we send a letter to Mr. Martin saying this is how you have your funds designated, how you want to spend them. Is this how you want to spend them next year? And if we hear no differently, then that's how we move forward. Okay. So this is the slide that I'm just going to give you the data, because I also believe that perception is reality. So according to our provider records, and all these providers are credentialed, we have 11 provider agencies in Bladen County. We have 1 licensed independent practitioner, and of course 1 hospital. And we have on our records that there are 20 site locations. What I have heard is that nobody's in these locations. So if that is what you believe and that is the perception, then we're going to accept that as reality and talk about how we're going to move forward on that moving forward.
So if that's the true statement, then why haven't y'all done something about that? I don't know if that's true, but if that's a true statement, why hasn't Eastpoint done something about these people not being in these buildings?
So actually, that statement has only been brought to my attention in the last week. Okay?
Okay.
All right. Just a couple more things about Eastpoint that are really important moving forward. We are an accredited body. We had to switch accreditations to prepare for becoming a tailored plan. And so we received full accreditation in March. We received full accreditation for 3 years. Not every MCO has received full accreditation for 3 years. You might want to check the information about that, but that's important. And we received a score on that 99.67 out of 100%. The other thing we're really proud of for the last 3 years, and the most recent survey is 2019, we don't have the 2020 data yet, but for 3 years, Eastpoint scored the highest MCO on this survey that is done on members. It's not asking Mr. Gillespie or Mr. Bullock what they think about Eastpoint, it's asking the people we serve. And on page 10 of your annual reports that I put in at your places, you'll see the chart. And Eastpoint represents the top line across there, head and shoulders above every other MCO in the state on how the members perceive us. So I hope when you have a minute, you'll take a look at that information. There's a typo on this slide. At the very top, it says Medicare. It should say Medicaid. And this may be the most relevant slide we talk about today, maybe. I want to talk about Medicaid transformation and what is getting ready to happen there, because it's so important that we all are on the same page with this. So, what is happening in 7 days, on July 1, is there are 5 what they call standard plans in the state. And they are private insurance companies, your Blue Cross Blue Shields, your WellCare, you know the names. They are getting ready to take over whole person care, that's physical and behavioral health care, for 90% of our members, right? So what that means in 7 more days is the people that we've been serving, many of them will get their care through these private insurance companies. And you may be very well aware of this. Please tell me if I'm telling you stuff you already know. But I want to talk numbers for you. Well, but first I want to tell you, the MCOs are set to become tailored plans. and we have applied to become a tailored plan. Those awards have not happened yet. They were supposed to happen on June 11th, and they were postponed for lots of reasons, but I think the whole Cardinal debacle played into the delay on that. We were told this week by DHHS that they will probably be making those awards in a couple of weeks, okay? But when the awards are made, then we will have a full year to implement. So we're slated to go live as a tailored plan next July. In the meantime, we will continue to care for the most severely impaired. But the majority of the people their care will be taken care of by Blue Cross Blue Shield, WellCare, whoever they choose to go with. They have the option of who they choose. So if I can do these numbers in my head, just to give you an example of what this looks like. Right now, we have 227,000 Medicaid members in our 10 counties. Bladen is 5% of that, right? So about 10,000 members on Medicaid in Bladen County. So once the standards take over, our numbers for the whole 10 counties, it's about 20,000 people. And again, these are the most severely impaired. These are the people who absolutely depend on us for care. They're your developmentally disabled, your severe mental health issues, substance use, that kind of thing. So if you take 20,000 left in the 10 counties, and right now you're 5% of our numbers. So again, I'm just running numbers. You take 5% of 20,000, that's 1,000 people left out of the whole population to receive service. You've had 10,000, now it's 1,000 that we would serve. So how the care is delivered to that most severely impaired population is going to be critical moving forward. And I absolutely want you to have the best care for those folks that you can. But I think it's really important. I don't know, did you know what I'm sharing? Because if I'm being redundant, then please forgive me. So, yes,
The number breakdowns, I'm trying to follow what you're saying. Your population now that you serve with Eastpoint, what percentile is broken down? Like how many would even be eligible for these 5 that you're talking about, that they would even garner?
Yeah.
You know, so in other words, when I think of Medicaid, I don't think of individuals who are gonna go out and they're under Blue Cross Blue Shield all of a sudden.
They are.
Okay, so Blue Cross Blue Shield, in other words, these are people not paying premiums, but they're gonna be the gatekeeper?
For
Is that what you're
Medicaid.
saying?
For Medicaid.
In the word PHP.
I'm sorry.
The PHP?
Yeah.
Okay, so in other words, they're just managing the care. These are not, I mean, these folks, most of the folks that y'all are serving they're not paying for this insurance or
Correct.
that kind of.
Correct.
Okay.
So they'll take them all, except for the ones that have been determined that need to stay in the tailored plans. And there's been a lot of work at the state level and on our part too, to see who stays. So let's round the number for purposes of discussion. Let's use 220. Whole Medicaid population in the 10 counties. So 200 will be under the management, you used the right word, of the insurance companies. And that's not just Eastpoint, that's all the NCOs in the state that will become much smaller in terms of numbers. But what's interesting, and I did not bring these numbers with me, but it's interesting to note that the dollars left are still, you ask about finances, we're still very viable with just that remaining 20,000 because the services, it's like there's a small population that get most of the dollars because they're the most severely impaired. So we'll keep dollars to manage these members that will keep our organization viable. But it's critical for us to become a tailored plan. That may have been way too much information, but I thought I would be remiss if I came and made it sound like things were going to stay the way they've always been, because they're not. It's getting ready to change. So let's talk about some of the things that Eastpoint has done to date. And again, much of this is for our 4 new members, and I hope that the remaining folks will be patient as we move through that. So I was talking about the amount of money we had invested, and you can't see that, but it's over $27.5 million since 2017 that we have moved from fund balance into provider rate increases, so that all of our providers can be maintained. And I know sometimes it sounds different, like when you hear, well, we give providers incentives to keep them going. Well, this is exactly what we've done. We've put it into rate increases, and the reason we did it that way is we didn't want to be unfair to anyone. So if you're a provider and you're providing a service, whether it's in Bladen County or Robeson County or Greene County, the rate is the rate, and we've increased it for all of our providers, so we would be fair to all of our counties.
Can we move those boxes off that screen?
I don't think
It's
so.
not
Robin
sure.
said we can.
It's part of the go-to-meeting. It's because that machine's on go-to-meeting sharing it.
Yeah, sorry. So the next slide. And this was spoken to earlier, and I think this is important too. Since 2019, we've provided almost $150,000 specifically just to Bladen in your efforts to address substance use and the opioid overdoses and the epidemic in the county. We funded the county substance use strategic plan, and then we also have funneled money into the use for the task force in this effort. I'm going to skip the We Connect project because I'm going to ask Kelly to talk about that. But we've also supplied since 2018 381 Narcan kits that have saved lives in your county to first responders. The next slide, mobile crisis. I know that this is not always what you want, and we're going to talk about what you want, but existing in your county now is a service called mobile crisis. And if somebody calls and they are screened, we call it screening, triage, and referral. If they get screened by licensed clinicians and it's determined that they're in crisis, we send these teams out into the community to provide crisis response in the community. And our standard for that is they have to be out there in under 2 hours. And we have a crisis provider in Bladen County that does that. And I think that I'm getting ready to turn it over to Kelly, because Kelly is clinician extraordinaire. Yep, so I'm going to turn it over to Kelly just to highlight some of the things. These are not things that we're promising we'll do. These are things we're doing right now. Kelly?
Who is the crisis employee in Bladen County?
It's Monarch, isn't it? Monarch.
Monarch. Where are they located?
Monarch, they're located across the state, but in Bladen County, they have a place off of, is it Peanut Road? I believe either Peanut Road or West Broad Street.
Across from where did it cross from, Burger King? Yeah, Burger King, went there from Walmart, a little place that you see, where it used to be the old insurance office.
The website says 412B Peanut Road.
Yeah, where did the old
Emory White.
old
Emory White.
insurance office.
Can we go back to the previous slide for just a second, just because I'll forget if I don't do it as I'm seeing the slide. So, the mobile crisis slide. So just a little bit more about the mobile crisis services that we're already providing. I think sometimes, just for clarity, and again, if I'm boring you, know these things already, you can quickly give me the, and I'll stop. But so for mobile crisis services for us, I think a lot of times folks automatically think that that implies a suicidal attempt or a suicidal gesture, thoughts, plans, something of that nature. I think it's really important to know that that's not necessarily the case with the crisis services that we have that are mobile across all of our 10 counties. A crisis is really self-defined, and one of the examples that I was actually processing with some staff recently, COVID's hit all of us pretty hard, a young family lost jobs because of COVID, didn't have any money to feed the family. So pretty distraught. Didn't want to kill themselves or anything like that, but really was just kind of at the end of their rope. They were in their own self-identified crisis, right? So we were able to intercept that call, get the crisis team into the field. And one of the really neat things about this service is that the licensed person responds on the scene to wherever that person might be. It could be Burger King, it could be the hospital, it could be anywhere. And an evaluation occurs. A part of that evaluation also entails really looking into the social determinants of health that individual family may be struggling with. When those things reveal themselves, we've recently developed and enhanced our internal platform. So we have some new tools in place that we're using. Don't laugh too hard at the name, but it's called Aunt Bertha. And we also have the NC Care 360. So when these crisis clinicians are in the field and these things are revealed, they have automatic access to our system to actually be able to identify resources on the scene to provide for these folks. So it's quite possible if Dr. Ellis's family were to call in crisis because they lost their job and they couldn't make ends meet and the family was hungry, before that crisis episode concludes, we would have actually link that family with a local food bank, maybe some other charitable resources. Sometimes it's linking them to benevolent funds to help with electric bills and things of that nature. So just to expand upon, what mobile crisis actually does, it's a lot bigger than just a mental health crisis. Yes, sir.
What is Monarch's role in that?
We pay Monarch to provide the service, and so Monarch employs the licensed clinician that responds to the person in the field.
So if we have someone OD, Monarch responds?
Well, if the person's in a medical crisis, EMS would respond. But if the person is having thoughts of overdosing or, it's unclear, it's not uncommon that Monarch would respond in conjunction with either EMS or law enforcement. We work very closely with law enforcement and EMS.
I have never heard of a Monarch being there the same.
Yeah, I'm not sure, specifically, but we are not permitted to send providers into an unsafe situation. So historically, if law enforcement want us to go along, they let us know in advance, or we've done some type of warm live conversation on the phone with a specific member, and then it kind of evolves from there. The crisis collaboratives are really pertinent in that discussion too. And each county is a little bit different with the level of involvement that they want from mental health, honestly, when it comes to law enforcement. So we try to think of creative ways to minimize the burden to law enforcement. But yes, so Monarch is the actual provider of service. I think we can go to the next one. One of the other things that we do, we have a system that we've gotten through contracts with the state where we're able to go in daily and we do sweeps of every individual in our 10 counties that's been booked, arrested, within 24 hours. So any of those individuals that come out on that report, we automatically pull them out. And we begin to look them up in the system and trace it back to see where we might be able to connect with that person. And if they haven't been connected and the need is there, then we immediately get on that by linking them with care coordination and also doing outreach with the local facilities to try to see, is this where this person needs to be, or is it the result of them maybe missing 2 or 3 Haldol injections and they've had a psychotic episode and now here they are in jail. Yes, sir.
I'll tell you one thing with Monarch, and this is something maybe that we need to hear, is whenever Monarch is in that site, the thing is, what services do they provide? What care do they provide? I think that might be just some of the reasons that we look at these facilities and they seem to be just standing there.
Mm-hmm.
But my thing is, they'll say, I'm here and got the mental health services or whatever, but they don't tell you what services that they provide. Mm-hmm. So is there any solution to that? You can't put that on the signs, you can't put information out to let them know what service they provide?
I think the answer to that's yes, and I think signage is actually one of the things that we're going to talk about a little bit later in the presentation globally, around just signage improvement period. But as far as Monarch and their services, that's maybe one conversation, and then mobile crisis as a service. That service is mobile intentionally because of the response rate times. you know, that the state identifies that they have to meet. You know, the providers and the MCOs are actually graded on those response times, so they have to be anywhere that they're called to within 2 hours. I can say, the last time I saw the data, we exceed those response times, much shorter than 2 hours. And I don't know the time that we've actually missed them. Yes, sir.
I want to ask like a scenario, and I don't want to jump the gun because
That's
you might be
okay.
kind of getting to it anyway. In an event, I know you explained a minute ago, you know, mental versus really a true healthcare crisis. But let's say, for example, you know, someone's called 911. It is a behavioral health situation. The sheriff deputy or whoever might show up, they take that individual to the hospital. They get there, they do identify that it is a behavioral or that type of thing that would warrant your service. Who is the one responding at the hospital to ultimately get that patient or person where they need to go? One thing that we were, and like I said, I'm not trying to jump the gun or with an issue, but one thing, one of the officers the other night said that a lot of times it is an extremely long time that they are with individuals before that individual is actually taken, you know, somewhere. And that, you know, that was one of the things. So I hope I'm not jumping the gun, but
No.
who responds to that situation at the hospital?
So, yeah, and I don't know if I'm gonna answer the exact question, so keep me honest if I'm not. But, so we really don't have jurisdiction in the hospital. If a person's under IVC. So if a person's under IVC, then, you know, there's there's law and statutes written that say that the individual has to be under the supervision of a sworn officer.
And what's IVC?
Involuntary commitment.
Thank
I
you.
apologize. Sorry, we have lots of those that we use regularly, but yes. So, even our crisis teams that we contract with, they have limited activities that they can do if a person's under an IVC. It's typically us, and I say us meaning the providers, or it could even be maybe our call center staff who initiates the IVCs. But once the IVC is put in place, there's statutes that say that individual has to be with a sworn officer. There's also statutes that say that they have to be transported. So it's a little bit difficult for us. I can say that, again, each county, each magistrate, each, you know, sheriff, there are different things, you know, that go on across the entire state. We have some counties where anytime there's a request for an IVC, it's an automatic call to us to dispatch mobile crisis. And we go out and we evaluate, hey, wait, is this really an IVC situation or not? It's very effective, but it takes buy-in from the magistrates, the sheriffs, and multiple levels before it actually goes into effect. So there's ways to kind of enhance it and try to divert unnecessary involuntary commitments is kind of the big initiative. But it's not always that easy because of the safety issues in the scene. So we have to work closely with law enforcement to get the clearance to go. But in a situation in the hospital, once the attending physician does the assessment and determines the IVC is going to be upheld or not, then that kind of guides what happens next and who gets involved. It's not uncommon that we have care coordinators in the hospital. We actually have a hospital team, you know, who services the hospitals. That starts with daily calls to every hospital across our catchment area and state facilities to inquire about any member that we might have that's there, so that if they are there, we can begin the process of trying to get them out. So we do come in that capacity. So I don't know if I answered you.
No, you
but
did.
that's-
Yeah, you did.
okay.
I was telling.
So the problem we have is like, it takes so long to get Eastpoint to get someone placed. Like the APS, adult services, we used to meet monthly, and we had all kind of trouble since COVID, we hadn't met monthly, and we couldn't hardly get adults placed. That was our biggest problem. We had people in jail for stay for months and months and months where we couldn't get Eastpoint to place them.
Yes.
So that's okay, I'm just,
No, I
So
mean, I
this-
think that's a
what
very
I-
valid point.
what a lot of things I'm learning today. I mean, you know, if I don't know it, and I'm kind of active, there ain't no in order to average citizen to know. You mean to tell me you take this jail report and you make calls to the jail every day?
We do a sweep in our system, and based off what comes out of that sweep determines what our next actions are. Yes, it does. The name of the
I never
system is
heard that.
CJ Leads.
That's
Yes,
the
sir.
reason I wanted to talk to you.
How are most of your patients, coming to you guys? Are they coming through direct calls to Eastpoint? Like you have families that they know about Eastpoint and they call your number and that's where these individuals are coming from? Or?
Yeah, the majority of our
So-
connections or accessing for services actually does come through our call center.
But there's no wrong door, no wrong door.
Right.
So who are they calling at Bladen County Sheriff's Office?
I don't call personally, but I can get you specifics on that if you'd like, because we
I
have
know
a
who they're
person.
contacting. Okay.
Now, what are you looking for in that suite when you say you make?
All we look for is there an individual that's in our catchment that's been booked, that has, a chronic mental illness or a psychosocial issue that we've been involved with and helping with that may have resulted in that person getting into trouble and then being picked up. Yes, and so in those situations, when that happens, it's real critical that we know, because we can try to intervene and make sure that that person gets back to where they need to be instead of sitting in the jail, just kind of waiting. A recent example was not in Bladen County, but we had a chronically ill member who actually assaulted, some staff members in a facility, and as a result, they pressed charges. There's consequences, right? But it just wasn't appropriate for this member and his ability to function to be where he was at. So we were able to work with attorneys, law enforcement, and the facilities to expedite the charges actually being dropped, getting that person out of the jail and actually into a state hospital where the person needed to be.
When you do your,
Mr. Hester, got the floor, Mr. Carson.
when you do your CIT training, do you go over with the magistrates as far as you guys being able to maybe come into play before the IVC is actually?
My understanding is yes, we do that, and we, again, COVID has kind of hit all of us, including the magistrates, right? There hadn't been a whole lot of, face-to-face meetings, but we actually, in all of our crisis collaboratives, one of the things that we do is we invite the magistrates, the judges, the local law enforcement folks to the table so that we can begin to exchange and have these types of information. The crisis providers are on board, with doing it. It's kind of a way for us to divert, right? To divert and to minimize the burden on law enforcement. For 20 years, we've been talking about, how inappropriate it is for law enforcement to be, tied down for 25 hours because a person, I used to work on a mobile crisis team. I was the person that, drove out and said, hey, here I am, how can I help you? I don't know that there's a perfect answer, but in some of our counties where that's what the magistrates have agreed to do, it is impactful. It doesn't always prevent it. Typically they're probably valid requests, but sometimes it does divert the IVC from occurring.
Mr. Ogden?
Could you speak to the one that I have more concern with, not spoken with, I know what I've spoken with, spouse about it, like, it's when young men, like, people come out of the jail system, and they were on drugs, and they haven't met behavior issues, and they've been a client at police form, and they go to jail. It's like I see them come out, and the guys from the probation officers, and that part of the DPS has said, we just waiting for a time frame because the medication is out. They have no routes to medication. And I'm saying, are they Medicaid eligible to get Medicaid? Do we follow those guys to try and keep them from repeating? Because the same one, you give them a month, they're right back in the same situation.
Right, and it's very unfortunate that a large majority of our male population, most of the time, they don't hit the threshold for Medicaid. Sometimes they do, but irregardless of that, yes, we do work on those situations. Anybody who's released from a detention center, local jail, prison, or even a state facility gets priority to access through our system. So if you are releasing somebody next week because you picked them up on possession or what have you, once we are notified or we pull it from CJ Leads and we know, then that person automatically gets triaged a level higher so that they get rapid access to whatever service it is that they need. To kind of take that a little bit further, we have some programs in place already specifically designed to work with these individuals. And the first one that comes to my mind is the TCLI program, the housing program. We have a couple of things going already. And it's on a slide, so I'm kind of getting out of order a little bit, but I'm talking too much too, so I'll just keep going. Right now, we have about, I think it's 16, 20, 21. So we have 21 Bladen members right now that we're either serving in TCLI or in REACH. And so to meet the criteria for those services, you have to be, it's basically the sickest of the sick that we have. Most of them have criminal histories, most of them have substance use concerns. And so our team, that includes our team, Eastpoint's team, not a provider, us, includes licensed people, it includes peers, it includes QPs, even APs. And so we wrap around that individual to make sure that they're linked, that they get what medicine they need, and that they find suitable and adequate housing. And if the person wants to work and is able to work, we also make sure that that happens for them too. It's kind of a no wrong door as well with TCLI. Once you're in the program, you're in the program forever. So it's not like we get them in and then we cut them off. We actually get them in and then we actually end up doing regular follow-up and even monthly engagements. Sometimes weekly. It just really depends on what that member might need. And the majority of those are folks who are coming out of state facilities or prisons and detention centers.
What's TCLI?
Can you might talk about what the status is on Eastpoint?
Yeah, sorry,
I do.
a little dry. So TCLI stands for Transition to Community Living. Oh, thank you. Thank you. So TCLI evolved from a DOJ settlement with North Carolina. Thank you. And Eastpoint is actually outperforming across the board in almost every category for TCLI.
What's TCLI?
Transition to Community Living. It's a it evolved from short story. It evolved from a lawsuit that says, you know, people deserve to live in communities, not in facilities, basically. Thank you so much. And so the state actually monitors. Yeah, and exactly, yes, it is a statewide lawsuit. So it impacts every single county in the state, and every LME MCO has a TCLI team. We kind of have an edge on the other ones because we've been so productive over the last 2.5 to 3 years. We had a little bit of a slow start out the gate, but we've exceeded the placement rates and housing options for our members consistently for the last 2.5 years.
So you're talking about housing options. What are you talking about? Apartments? You paying the rent? You're buying them a house or what?
All the above. All the above. We try to make sure that the member has choice. So we talk with them about what it is that they want, and then we compare that with what the available options are, and then that sort of guides the process. So if, Mr. Cogdell, if you were a TCLI member and we were trying to assist you with suitable housing. So the lawsuit says housing has to be suitable. So there's HUD inspections, there's a list of items that we have to go through that the federal government says we have to do before we can put you in a housing unit. Sometimes it's mobile homes, sometimes it's apartments, sometimes it's really nice small homes. We also do bridge housing. What bridge housing is sometimes we have to pay for members to stay in hotels until a housing unit becomes available. The housing crisis is not just common to our 10 counties. I mean, there's a housing crisis across the state, so sometimes it is a little bit challenging. But even through that, we're doing very well with that. Yes, ma'am.
And I would interject, Kelly's probably not going to brag on herself, but if I'm not badly mistaken, when COVID hit, most people, these teams stopped interacting with the members for fear of contracting COVID. Our TCLI teams stayed out in the field. We provided them with PPE and made it as safe as possible, but they really put themselves at risk to make sure that people were still tended to.
Yeah, absolutely, we did. There was no interruption. Yes, sir.
Mr. Chairman. I was going to say, you mentioned something a minute ago, and I appreciate you helping people get housing, but you said for those who, quote, want to work and are able.
Mm-hmm.
What about those who are able to work but don't want to work?
Very good point.
That's a whole different story.
Yeah, that's a whole different story. I'm sorry.
No, go
Probably the most clinically sound answer I should give you for that is that it happens a lot. And so what we do, we have special training that we put our staff in to try to help motivate the individual to want to have gainful employment. Most of the time it works out, some of the times it doesn't. Sometimes the member might be in the process of applying for disability benefits, and so it's not appropriate for that person to work. So it really is just kind of determined, depends on what that situation might be. We have special services across our network that's called individual placements and supports. And those are specialized providers who actually go into the community where the member is, and they actually evaluate that individual's ability to work. It's I don't know, you remember like the ASVAB test that the military does? Well, it's not that, but it's kind of like the behavioral health version of what are you good at, what do you like to do, and where would you, what would be suitable employment for you if you would, if that is your desire. So the key concept is that whatever the member, the member leads, guides, and directs, their plan of care. And then if that plan of care is going a way that is maybe not beneficial, then we use our trained folks to intervene and to try to get that back on track. And we do really good work. As Sarah said, through COVID, we were there face to face. It was hard because even our moving companies were not responding to us to go in and move personal property. So it was not uncommon for you to see us out suited up, moving furnitures and things like that to make sure that these folks were able to secure the housing unit that we were able to locate. It was heavy, but it was really good work, and it went very well.
One of the questions I have, you might be going back a step or two, but regarding the mobile unit, if EMS is on the scene because of an overdose, what is the responsibility of Eastpoint or Monarch in that case?
If there's a medical emergency, as if you've already invested, and I'm not EMS, so I want to speak for them, but if you're already in a medical crisis or medical emergency, we have no jurisdiction there. Now, if there's a scene that they go to and maybe you're having a medical emergency and they're treating you medically, but your brother is there with you and he's distraught because you're in crisis, it would not be uncommon for mobile crisis to then arrive and actually provide a crisis intervention to your brother who's not medically critical while they continue to provide your medical service.
But do Eastpoint, do they provide Narcan on the scene like that?
We dispense the Narcan prior to, so we usually dispense our Narcan.
It goes to EMS.
It goes
We put
directly
it
to
in the hands of
facilities.
EMS.
Because the other day they were saying that and Mr. Martin was there, they said something about they had tried something through Eastpoint and it was slow responsive to them.
I'm not sure what that would be because there was actually even a few local articles about how effective our Narcan distribution plan had been, specifically even in Bladen County. So I'm not sure, but if you have specifics to that, I'd be glad to take that back and follow back up on it, because that would certainly be something that I would take issue with in my role, and I would work it back to see.
Now another thing on Monarch, on your website, there is no after-hour crisis phone number on the website.
So. So the 800 number that we have published is that number. It's one number for everything. And the state, by contract, we required that it be that way because there can be no wrong door and there has to be 24/7 access to services. So you can call our 800 number at 3 o'clock in the morning and you're going to get your licensed clinician that answers the phone.
But wouldn't it be nice though if you had that number on the website so that if someone looks and says, oh, they don't have an after-hour number? Because I thought you didn't have one.
Yeah, and I thought that it actually was on the website, so.
Is it on the website?
No, if you didn't see it on there, then it's
Yeah.
not up
I mean,
there, and we need to make
it's
sure
like
that
a
it
here.
goes
Yeah,
up
we'll
there.
go back
Yeah,
and-
yeah, but definitely.
Yeah, it should be there,
Right.
the answer to that.
Okay.
I was just gonna add while they're looking at that about
Oh, yeah.
the
Yes,
EMS.
they should have their-
Our supply of
Yes.
Narcan,
That's exactly right.
It's 19, okay.
Yeah, that should be there.
the supply of Narcan that we are able to distribute from EMS, we don't go out and purchase that because it's a controlled substance, of course, but it comes to us from the state. And we have made, William probably knows this, we've made multiple requests on behalf of our county. We distribute, then they're like, yes, this is helpful, we need more, and we have made multiple requests and gotten it. But it's dealing with the state, so we can't say we need 20 tomorrow and get them tomorrow, but we have run those requests up to the state regularly, and they've been fairly responsive.
So now you deliver to EMS as well as law enforcement?
I know
EMS
EMS.
distributes it out
Yeah.
to the rest of Bladen County.
I mean,
EMS.
Yes. Mr. Patterson's accurate, so we would give the supply to EMS, and then the EMS director, I think, then takes, the responsibility of dispersing. One last point on this, this slide, and I apologize, I always talk too much. It's a weakness and a strength. The Oxford House program, that's something that, you know, we're actually really proud of, and we're on the cusp of actually rolling out in Bladen. I don't know if you're familiar with the Oxford House program or not. Again, if you are, I don't want to bore you with that, but it's a self-governed entity basically for individuals who are recovering from substance use disorders. And it's individually, it's homes in the community where these groups of individuals live and work and govern their home. So it's a recovery program for folks who are coming, you know, through the substance use system. We've not had a lot of those particular homes, but we just recently, how many months ago, 3, 4 maybe months ago, secured a contract with them to expand their homes into our catchment area. We just actually got the first one up and going, and so now we're moving forward to the next one, and that's actually very exciting. It's proven across the state. There's lots of hype about it, so we're very excited about it, and that also you know, is coming here.
The goal is to put one in each one of your counties.
I'm sorry?
The goal is to put one of those office homes in each
Yes.
county.
Yes, that's the goal. Yeah.
It's long been needed in Bladen County. I'll show you some data in a few minutes.
Yeah. Yeah, we're pretty excited about it. We think it's gonna, you know, it's gonna provide a lot of opportunity, I think, across our 10 counties, because I could be wrong, but I don't think you have to reside in Bladen County to get into Bladen or Robinson. It can transfer to any of our 10 counties, basically. If you live in any of our 10 counties and there's room in any of the Oxford houses that we are contracting with, you have access to that bed. Yeah, so, yeah, okay. So maybe go to the next slide, let's see, because I've talked way too much about that one. Actually, I just thought of something else, I forgot, because this is, the only other thing, and I apologize, this again is my weakness. We just recently also launched a really innovative approach to assisting folks who are recovering from substance use issues. It's called We Connect. I don't know if you guys are familiar with that or not, but it's a really neat incentive program for individuals who are struggling with substance use, who are on the path of recovery, and they need a little bit of a nudge, they need some personal coaching, they need some stuff to keep them on the straight and narrow, and to kind of stay committed and married to the recovery. So it's an app, and these individuals can download this app, and then they earn incentives to actually stay into their recovery process. We've launched it, I think it's been going now for 3 months, maybe 4. We're on the cusp of being able to now roll that out, because we've had the first few months to kind of work out some of the kinks to that. And we've actually, I looked at the numbers this morning, and we had a couple of members who've actually earned over $100 from using the We Connect app. That money can then be spent, you know, for medications, to help with utility bills, rent, whatever it might be. And it also kind of plays into the social determinants of health issues that we're seeing across our 10 counties. It's a way to incentivize them for coming to treatment, but to also then offset maybe some of the social determinants that might be getting in the way of them staying in recovery. Sorry, I want to be sure and tell you about that one. So next slide. Yeah, so this is one that Victoria can probably speak extensively about, but we actually have a whole person care pilot project that we've initiated with our friends at the Carter Clinic in Bladen County. It's at the Elizabethtown location. It integrates physical, behavioral, and substance use services underneath the one umbrella, and also incorporates pharmacy services. So that if Dr. Ellis is in treatment, he only has to go to the one place to get whole health care. That's kind of the wave of the tailored plan. and kind of a segue in for us to kind of be a step ahead of the curve when it comes time to go live with becoming a tailored plan. Participants receive Visa cards to help address the social determinants in this pilot project as well. And then those can then be used for prescription coverage, medical appointment, transportation, housing, whatever it is that they need to use those funds for. They have access to do that through this particular pilot. I'm not sure how long we've been doing that one.
It's been for about, what's it, like 9 months.
Yeah, and it's already proven quite effective.
Never
And
heard a word about it.
That's one thing, how do you advertise
Never
that?
heard the first thing about it.
I don't honestly know what the advertisement or the marketing may have been with that. A lot of times we try to work in conjunction with the providers because the provider, again, is the provider of the service. We fund the service, we help develop it, we help share information about what might be the best or most pertinent for this county or that county or this demographic or that one by drilling down our data. But a lot of the marketing campaign efforts tend to come from the providers. Again, very good point. Something that we need to look at quite a bit more aggressively, I think, as we move forward. So thank you for the feedback on that.
And just to add, with this particular pilot program, it's in conjunction with UNC Health System as well. So we have one of our smaller providers working alongside of one of our larger providers to address the social determinants of health, because we know that transportation is a barrier in our rural area. We know that prescription costs is an issue. We also know that housing is an issue. So they looked at all this data. They did a complete data analysis on our entire catchment area, including Bladen County. And they came up with a proposal to say, okay, your folks need assistance with the social determinants of health. And so that's why we incorporated Visa cards.
Is it possible, and I don't think there's any conflict of interest, that I get a lot, you need to send me from around help, I get it, being on the board. Is it okay for these type of programs to be keyed into the commissioners, where this information will flow directly to them, but either you give it to the county manager, where we can have access to these different types of programs? Can that be done?
Yes,
Absolutely.
yes.
The information needs to flow to the media, not,
Yeah, I'm saying,
it's not 9 board members,
I'm
because
just
we're still
saying-
gonna get the word out.
I'm saying, but make sure that we see it
Yeah.
when it comes
That's
out.
your job.
Yeah.
Make sure it comes, it flows to the whole system.
Yeah, and I think Sarah's gonna talk more about that specifically when she gets back up here. I think we recognize there's a need to really enhance, that communication. And we have a solid plan for that, so, yes, sir.
And I'm not trying to jump out again, but
That's okay.
where are your locations in Bladen? Y'all mentioned that you've got 20 sites. I mean, and then a funny kind of question, how do y'all advertise? And who are the providers? I've been here 25 years and I don't know one. And I mean,
And how one understood in the
And
building.
yeah.
That's
I mean, I'm just asking, I'm not trying to jump the gun again, but I'm just saying,
Perfect transition.
I can't believe I don't even know who they are.
So, I think we all had our eyes open during the Come to Kelly meeting. I mean, these are the folks who really are intimate with what's going on in our county, and I really appreciate them being here, and I appreciate your interest in what they had to say. And I think we need to talk about and address some of the things that you just asked about. So, are we going to continue, or are we moving into closed session at this point?
What is your reason for going in closed session?
So we're gonna talk about expansion or locations and that kind of
So
information.
when we come out of closed session, then we'll have to report back to the public.
Okay.
I make a motion that we do it in closed session.
Second.
Motion by Ms. Marie?
Mr. Peterson,
No.
Mr. Gillespie,
Yes.
Mr. Cogdill,
Yes.
Dr. Ellis.
Yes.
Mr. McGill, Mr. Bullock,
Yes.
Mr. Hester,
Yes.
Dr. Mungolins,
She's not on the call anymore. She dropped off about 5 o'clock.
Okay, let's just take a straight break, and in about 5 minutes, we'll bring him back.